Good morning, everyone. I think it's fitting that we begin today talking about what happens to patients, and at least the part of MHE that is really the directly understood clinical problem. And it's interesting if you sort of list the manifestations of MHE as diagnostic entities. They're basically growth deformities, the formation of osteochondromas, and these peripheral chondrosarcomas, which are thankfully very rare. But similar to orthopedics, if you look at most orthopedics, there are only a couple of diagnostic entities, arthritis and fracture, and yet if you look at the coding manual, so what all of medicine uses to decide, how we code different procedures or interventions, orthopedics has more codes than any other specialty, even if you just took fracture and degenerative arthritis. And I think it's similar today. And so we only have maybe a few diagnostic entities, but just like in real estate, in orthopedics, location matters. And so we're going to learn about the broad array of locations where these different problems happen and the really significant clinical challenges they present. So we'll begin learning about the effects on growth and in children. John Dormans is obviously an expert in pediatric orthopedics. He, I think, of all the people in the room, is the first person I met. I was a medical student doing a research project, and I drove up to Philadelphia to go through some of his patients with him. He was a very gracious host for the afternoon I spent there. He is well qualified. He is one of the only people in the country who is truly what I guess the young Dr. Eaton wants to be. He is an orthopedic oncologist who really only does that for children, which is rare. He also has a broader practice in pediatric orthopedics generally. So without further ado, we'll let him get started.
Good morning. It's good to be here. It's a privilege and an honor to speak to this group. Maurizio told me I could not wear a tie today, so I didn't. I found a sweater that had patches on the elbows. So I'll fit in with the crowd here, but it is a pleasure and an honor to interface with the people that are really hold the future of this condition in their hands, trying to find better ways to treat this. What Dror and I and Kevin do, I think, really needs to be put in the shelves of history, surgically removing and realigning. Hopefully someday there will be better ways to treat this condition. But I'd like to thank Sarah and Craig in particular for their involvement with this. This is really the model group for patient advocacy effort for a rare condition, and the 1-2 punch, Sarah's energy and connections and all the hard work she's done, and Craig's political connections, and he's really putting this in front of the legislatures and people that can make things happen for research and education. So that's tremendous. And then also Jen and Maurizio for taking the time to organize all this. We know Jen put many hours into this. I'm told I have 40 minutes. I probably won't use all of that time. This is a slide from the Fantasia event from about 2 years ago in Queens, New York. Sarah told me that Michael Bloomberg was going to be there, and I didn't believe her, but sure enough, he showed up. And it was very impressive to see how they've worked to raise awareness and raise funds for research and education for this condition. So my goal here, probably in the next 30 minutes or so, is to try and take you through what goes on in my mind when a patient walks through the door with MHE. My practice is 50% tumors and 50% spine. We see a lot of kids with MHE for multiple different reasons. And each week we probably see 10 patients with MHE. Some of those are new. Sometimes they're young, sometimes they're older. But this condition has been around for a long, long time. The first description in England, or in English rather, was John Hunter in the 18th century. Virchow gave it its name. First description in American literature, 1915, and then Jaffe differentiated it from Aliase or enchondromatosis here just recently. So this has been around for eons, and yet just in recent history have people become interested in the condition. The prevalence is about 1 in 100,000, so it's about the same prevalence is clubfoot, idiopathic scoliosis. They're all about 1 in 1,000. So this is not common, not rare, but we do see a lot of it. And it's defined by these cartilage-capped prominences of bone arising from the physis. And the physis, the growth plate, migrates away from the exostosis, and they can be pedunculated like your thumb or broad-based sessile and anything in between. Males are affected slightly more than females and tend to have a little more involvement, males more than females. The autosomal dominant with near complete penetrance behavior has been noted for a long time, and I'm not going to be able to tell anyone in this room anything about the mutations. The mean number of locations involvement varies widely. I've got patients with just 1 or 2 bumps, and there's others with many, many, many bumps. The average is in the 15 to 18 range. The life expectancy and longevity is said to be normal. I'm not sure that's entirely true, but that's what's reported. The risk of malignant transformation is probably around 5% if you follow patients long enough and remove the selection bias of the publications coming out of tertiary referral centers. It tends to affect the most commonly growing ends of the long bones. It's known as Phemister's rule. It's the same for osteomyelitis, but this tends to affect the most rapidly growing ends of long bones. And years ago we did a review of our cases at CHOP, and sure enough, the distal femur was number 1, the proximal tibia was number 2, the proximal humerus is number 3, so as expected. But it also involves, small bones of the hands and feet and other locations that we'll talk about. The genetics, you know better than I, the EXT1 mutation, these patients tend to be shorter, they tend to have more exostoses, there's more pelvic and flat bone involvement, and the deformity and sequelae tend to be worse than those with the EXT2 mutation, and there is some with an EXT3 gene mutation, I'm told. The differential diagnosis, it's usually pretty easy. The diagnosis you can usually make just from across the room without x-rays once you've seen enough of it. There are some variants. The Trevor's disease or dysplasia epiphysealis hemiamelica is essentially, it's said to be an osteochondroma of the epiphysis. They're really not true osteochondromas, but there's bony exostoses, usually cartilage capped in continuity with the joint. They come off the epiphysis, so it's the other side of the physis. And likely a completely different disease, no malignant transformation reported with Trevor's. And then there's this weird metachondromatosis, which seems to be kind of a combination of Trevor's and MHE. And they also have enchondromas, so it's like a combination of different cartilaginous lesions both in the central portion of the bone and the periphery. I've got a handful of patients with that, and it's different. FOP, Fred Kaplan here in Philadelphia is really done the work with FOP. I'm sure you all know Fred and are aware of his work. Usually it's pretty easy to differentiate FOP from MHE in many different ways, but I put it on the list. Enchondromatosis, usually they're solitary, they can be multiple, they can be associated with Alié's condition and Maffucci's, but these are enchondromas. They're occurring on the central portion of the bone. And then we also see a lot of exostoses in kids with radiation. I see a lot of kids with high-risk ALL, acute lymphocytic leukemia, and a lot of those patients have had total body irradiation, bone marrow transplants, and a lot of those will have exostoses from their radiation. And then trichorhinophalangeal syndrome and others. There's, if you go to Smith's recognizable patterns of human malformation and look up osteochondromas, there's about 5 or 6 different genetic conditions that have osteochondromas as a feature. Generally, the clinical presentation when a patient walks into my office, they're the diagnosis has already been made. When it hasn't, it's usually a baby. Sometimes the diagnosis is being made prenatally now with the fetal program at CHOP and other prenatal programs. They're sometimes picking these up on fetal ultrasounds late in the third trimester. But the patients complain of a bump. There's a bump, and it's either sessile or pedunculated. It's arising from the growing ends of long bones. The vast majority are diagnosed in the first decade, and it tends to be earlier and earlier nowadays. One can also see limb malalignment, leg length discrepancies, angular deformities. The patients tend to be a little shorter than average, but it's the bump that is bothering the patient. Here's some examples in the upper right, a fairly large pedunculated osteochondroma coming off the back of the femur. Here's an AP X-ray of the knee, and you can see osteochondromas about the metaphysis of the distal femur, the metaphysis of the upper tibia and fibula. These can get in the way of range of motion, so one often sees restrictions of range of motion. There can be soft tissue entrapment, impingement, especially around the back of the knee. The femoral popliteal artery can become entrapped. We've had a handful of cases where the artery is actually crushed between two osteochondromas, and you have to excavate and free the artery or the nerve. The perineal nerve can get entrapped at the upper fibula such that the patients have a foot drop. We wrote a paper years ago defining this heel walking extinction test, and many of those cases parenthetically ended up as legal cases. The patients were upset that it wasn't diagnosed earlier, and by the time it was picked up, they had an irreversible nerve deficit. Really nothing could be done. So it's best to pick those up early. In this heel walking extinction test, you have the patient walk on their heels, and then after a minute or two, if they lose strength on one side, that's a positive test, and then you get an EMG nerve conduction study that clinches the diagnosis. And generally, if they're picked up early enough, you can remove the osteochondroma and the nerve will come back. Forearm and elbow, knee, and ankle are where you see the angular deformities, and we'll talk a little bit about this. I'm not going to get into great detail about the different carpentry options for fixing this, but I will touch on some of the things that we do. The ulna seems to be more involved in the radius. You can see this is a rather advanced deformity here. The carpus sometimes can slide on the distal radius, so there's this ulnar translocation of the carpus or the wrist on the distal radius. And we'll talk a little bit. It was great to see Maurizio's slide about the questions for this conference and see the number one question is, what is the natural history of this lesion? And you can drill down on that, and what's the natural history of wrist and forearm deformity? What's the natural history of ankle and knee deformity? And we'll talk a little bit about that. So generally, we make the diagnosis. The patients come back every 6 to 9 months or so. They come back earlier if there's red flags, and we've listed some of them there. When the patients come back, I ask the family to keep a list, a ranked list, a prioritized list of what's bothering the patient the most. The families come in and they say, this is number 1, and this is number 2, and this is number 3. So we take that list. It means a lot to us. They have time to think about it, write it down. And then I have my list of things that I'm thinking about that they might not notice, like back pain and ankle clonus could mean that they have an osteochondroma growing into the spinal cord, or if they have a leg length discrepancy that's progressing, or an angular deformity of a lower extremity, or a radial head dislocation. So there's things that we look for, and there's things that the family brings to us as far as what's important to them, and that approach seems to help quite a bit. The physical examination is pretty straightforward. I'm not going to get into the details here, but we look at everything carefully, measure things. We like data-driven decisions, so we'll get heights and we'll measure angular deformities. And Dror will talk about this. Dror's done a great job with creating a classification, an approach to measuring and defining alignment, which is very helpful in surgical decision making. Careful neurologic exam, again, looking for the early detection of what can go wrong, things like early nerve compression, back pain. an expanding mass in the scapular pelvis that even in a 16-year-old could be a low-grade chondrosarcoma. We've had a handful of those, as Craig was telling you, the heel walking extinction test. So we look at the spine and the extremities, x-rays. Generally, that's guided by the family. We take their list, and if they're concerned with 4 areas, we'll get x-rays of those 4 areas, and then there may be something else that I'm concerned about that the family's that's not on their list, and we'll work together to get the x-rays ordered based on what's going on with the patient. Special studies are sometimes helpful, and we'll talk a little bit about that. These are examples of osteochondromas arising on the inside of the spinal canal. This is C2. Here's the dens, and you can see the osteochondroma compressing the brainstem. And here's another look at it on MRI. Here's a more extreme example of an osteochondroma rising from the external surface of C2. This is a rather large one, and when you see something this big in an axial location, you think about, could this be a malignant transformation to chondrosarcoma? Usually not in a child, but as you've heard, it does happen. Spine involvement is something, there's more awareness now. One of my friends and colleagues, Jim Roach, who's now in Pittsburgh, did a study where they just looked at all the MRIs on patients with MHE, and they thought in their study 30% of the patients had osteochondromas of the spinal column, and they recommended MRIs for all of the spine for all patients with MHE. I think it's good that they brought awareness to this. I think the recommendation for routine MRIs may be a little aggressive, and there was probably some selection bias involved with their study. But the point is, look for it and do the physical exam. If there is cord compression, the patients will have long track signs, clonus, and that's a big help for me. If they have back pain and clonus, they get an MRI. If they have back pain, they usually get an MRI. Craniofacial involvement, very rare. This was, and I'd like to thank Dr. Harsha, who's in the audience. He's one of my fellows who put this talk together, but he found this. I wasn't aware of this, but there's this Jacob disease, which is a facial flat bone, intramembranous bone formation osteochondroma. It's very rare. More on the spinal compression. You can also get pressure on peripheral nerves, nerve roots, spinal cord, cauda equina, brainstem. One can see fractures of an exostosis. Here's a large pedunculated osteochondroma rising from the medial distal femur, and you can see there's a little fracture through there. Those are distinctly rare, but about once a year we'll have a patient come in with increased pain all of a sudden related to an injury, and they've fractured a pedunculated osteochondroma, and generally you either treat it conservatively or take it out. And then malignant degeneration, we talked a little bit about before. Forearm involvement, this is one of the big areas of controversy, and we really don't fully understand or understand well the natural history of the forearm in MHE. And this is a great learning opportunity for residents and fellows when the patients come in with it's an autosomal dominant condition, so the child and the parent usually, you've got a fast forwarding of the natural history by talking to and looking at the parent when the parent's involved. And I learn probably more from the parents than I do the children. And sometimes the parent has a horribly deformed or abnormal forearm, yet they're perfectly fine. They've never had surgery, they don't have pain, they've got great function. And in other times they are having lots of pain and problems, and it's very difficult to predict the difficulty that the parent is or isn't having from the x-ray. There's not a good correlation, at least from what I can tell. And after looking carefully at the literature, I think these studies fall far short of the mark in helping us define who's going to get in trouble and who won't. The most common bone affected, of course, is the ulna. The radius is also affected, and they can get radial head dislocations, carpal subluxation. We talked about ulnar variance differences. That's where the difference between the length of one bone is different, the ulna generally being shorter. Loss of motion, instability, etc. And there are some good natural history studies. Ken Noonan and Chad Price in Florida looked at patients, adult patients, and found that subjectively the majority, 88%, were doing well, but when you looked at them objectively, measuring and grading the amount of pain, there was more problem than apparent at first glance. But again, there's no hard and fast good rules, nothing much here that's too helpful for me in deciding which children are going to go on and develop pain and problems. Another study by Bob Stanton, formerly of AI DuPont, now in Florida, trying to help us predict who is going to get in trouble. And what they found, and what I agree with, is really it's the radial head. When the radiocapitellar joint starts to subluxate or dislocate, that tends to be the onset of pain and problems and stiffness. So we try and keep the radiocapitellar joint intact. But no great rules for this. Forearm deformities, the treatment options, most of the time we're observing, and I think observation is key. I think orthopedic surgeons have to resist the temptation to make the x-ray better. It's the patient, and I think we tend to over-operate on MHE. I think the vast majority of problems can be left alone unless the patient is hurting. So I put a lot of emphasis on the patient's list and what they're saying, and tend not to operate unless there's some defined problem, especially complex operations. Simple excision is the most common operation for the forearm. Excision with ulnar lengthening and radial realignment we'll talk a little bit about, and then you can create a one-bone forearm as a salvage operation. This is one of the several classifications that's out there, and I just put this in here, or Harsha put this in there to demonstrate the variability of what you can find from very minimal deformity or problems as shown here to major deformity with dislocation. This is that radiocapitellar joint. Here's the normal radiocapitellar joint that allows you to rotate. It's a very intricate joint. And this one, of course, is these two are dislocated. I don't use this classification, but it just shows the variability and helps with communication sometimes. This is Peter Waters' work at, this isn't Peter Waters' work. This is just a slide of indications for simple excision of a bump. And here's an example. This is a patient we did surgery for about a week or two ago. He had this big osteochondroma arising from the volar surface of the distal radius. He had medium nerve symptoms, numbness, tingling of the thumb, index, and long finger. And here's the post-op just showing a very simple excision, just mobilizing the nerve. We get around the base of the osteochondroma, clear the base, and then take an osteotome, which is a curved chisel, and take it off. So it's very simple, a relatively easy surgery to do. So simple excision, those are the indications. The outcomes are generally very good, minimal complications. And the risk of recurrence, they won't recur unless the osteochondroma is in continuity with the growth plate. If the growth plate is forming actively bone and the osteochondroma is in continuity with the growth plate, then that after excision it can continue to form new. But once they've migrated away and are separate from the physis or the growth plate, it's not going to recur. It doesn't ever recur. And then this is a diagrammatic representation. This is from Peter Waters, friend and colleague in Boston, children's pediatric hand surgeon. And he essentially wrote up what we had been doing for about 10 years for most of our forearms. This is a relatively simple operation. And again, the problem here is the ulna is short, the radius is long and crooked. So what you're doing is lengthening the ulna with this simple step cut osteotomy. I use an external fixator just temporarily for 10 minutes in the operating room to distract, and then we put a little plate on. And then we take a wedge of bone out of the distal radius just to realign it, and usually secure that with K-wires. But it's like a front-end realignment, very simple operation, lengthening the ulna, realigning the distal radius, and the outcomes are pretty good with that. The trouble here is defining who needs this operation, who's going to get in trouble and who isn't. And again, you know, we're not operating on the x-rays, we're operating on the patient and trying to gauge their real and future potential disability related to these problems. And here's just an example. This isn't probably the best example, but this is probably actually a poor example, and it illustrates how difficult it is to recreate the anatomy. These bones, even after the operation, are still bowed, and you still have distal radial ulnar incongruity. And so this patient is probably better, but not cured and not normal by any means. And it's a pretty big operation. So this is not something that we undertake lightly. And then finally, the salvage operation, the creation of one bone forearm. Here's the picture of that. This patient had a radial head dislocation and had severe elbow pain and a painful bump. So we took that radial head out and then fused the two bones together, as shown here. And that, I've only done this operation 4 or 5 times. This is truly a salvage operation for patients that have severe pain. The lower extremities, and there's other options also, and George's done a great job of defining other approaches. I'm not going to get into the additional carpentry, other options, but suffice it to say there are lots of different deformities. They're all snowflakes, they're all different, and so you have to individualize treatment for each patient. Lower extremity, again, the natural history is not well understood. There's an opportunity for the young clinicians in the back row to do this, and it's fun research because you've got a built-in control with the parents often. But again, Ken Noonan, looking at the lower extremities, especially the ankle. And here's what happens about the ankle. The fibula is short, the tibia is long, and so the ankle goes into valgus, and that biomechanically is a malalignment. The talus can start to subluxate in the ankle mortise, and the patients can get pain and stiffness. But again, my experience is that some of the worst looking x-rays, you think, oh, this patient has to be really hurting and doing poorly, and you ask the patient and they're fine. Their ankles are asymptomatic, and others with symptoms, their x-rays aren't as bad as you would expect. So anyway, Ken in this study found lots of radiographic changes. There's lots of angles that are off. There's subluxation, tibiotalar tilt abnormalities, et cetera, et cetera. But when you ask the patients, a lot of these patients are doing really pretty well. Only 8% reported pain and arthritis that interfered with their work. More had less severe pain on an intermittent basis. The hip is an area that's attracted a lot of interest, and again, it's the different osteochondromas restrict range of motion. The hips can sometimes subluxate or even dislocate, which is exceedingly rare, but it's the patients experience pain, loss of motion, and there is this new surgical dislocation option where you actually take the ball out of the socket and then can work around the base of the femoral head and neck and remove these osteochondromas. We've done a couple. We're very cautious with this. It's a very aggressive and potentially risky operation, and we have not jumped on that bandwagon. Often the osteochondromas can be removed without surgically dislocating the hip. So it just depends on the individual characteristics of the patient that you're working with and what their MRI looks like and how their symptoms are. But it's a lot of detective work trying to figure out which bumps are causing the problem and where the pain is coming from. Lower extremity alignment abnormalities, leg length discrepancy. This patient had valgus that was bothersome for her and had a distal femoral, very simple distal femoral osteotomy realignment procedure, and there are measurements that are very helpful in deciding what operation to do and how to do it, and George's kind of been the pioneer of this type of work. I don't do a lot of this. Rich Davidson is one of my associates that does the type of surgery that Dror does, and I'll send these patients to him usually. But this patient did did great, has currently no problems. And the other new thing is this 8-plate procedure, guided growth, where you put these little simple 2-hole plates with screws, one on either side of the growth plate, and you're guiding the growth of the physis. You can take these out and the growth is supposed to resume, usually does. I don't think it always resumes. But with this guided growth, you can do surgeries at a younger age and have a little more control over the situation related to growth. But a fairly impressive result here in this patient. We talked about the spinal column. My practice is spine and tumors, so I see a lot of spine tumors, and many of those patients have MHE, and we've talked really about most of this. Most of these patients do quite well. Here's, I think, another example. This is a patient of mine, a 16-year-old, who presented with paraparesis, could not walk, lost balance, bladder control, had sustained clonus at the ankles, just an acute onset of paraplegia. And these are intraoperative CTs retracting the spinal cord, just removing this bone from the canal through a laminectomy. It was a fairly large mass, so we did stabilize, and she's now 21 years of age and doing well, and everything worked out pretty well. We do 2 or 3 of these a year. So, and the other is the shoulder girdle, the scapula. More and more we're finding that sometimes they'll have osteochondromas arising from the inner surface of the shoulder blade or scapula, and that can be very painful for the patient, and it's not too hard to remove those. And then also the other area is the osteochondromas arising from the inner aspect of the ribs, pushing on the lungs or heart. We have a small series we're reviewing that we did initially with the cardiothoracic surgeons. We now no longer do them do the surgeries because it's pretty straightforward. But you just open the chest, spread the ribs, or remove a rib, and then resect the osteochondroma. But these can be very painful, and it's really the history that clues you to look for these. You can't see them on the plain x-rays usually. Here's a plain x-ray patient with a big and sometimes in retrospect you'll see them, but you usually need a CAT scan to see the lesion. The pelvis, again, the scapula, pelvis, spine are the areas where we worry a little bit about malignant transformation. Vince Eaton had his chondrosarcoma arising from the scapula. He was a young man, I think 16, 15 at the time, and had pain and a slowly growing mass, and one of my colleagues did the biopsy, and sure enough, and we sent it, CHOP pathology looked at it, thought it was chondrosarcoma. We sent it around to a couple different areas, other bone pathologists, and it's difficult. It's a very difficult call, as many of you know, differentiating a benign osteochondroma from low-grade chondrosarcoma, and you look for diploid nuclei and hypercellularity and other factors, but the consensus overwhelmingly was that it was indeed a low-grade chondrosarcoma, so we resected it, and he's, thank God, done well without problems. And we've had probably 5 or 6 other young adult patients with chondrosarcoma, and many of the parents, there's probably 20 parents I can remember with chondrosarcomas, and some of those have died. So one of the jobs of our team when a patient comes in is to get the parent plugged into adult oncology care. 3D reconstructions, again, just showing large pelvic osteochondromas. Scarring, we did some work, Harish Halsekar, probably 4, 5, 6 years ago. We just noted that a lot of the kids coming back, who had surgery by me and at our center and other centers, had these keloids and hypertrophic scars, and much, much more than any other type of patient. And so Harish designed a study and carried it out, and sure enough, there was a attempt to find a control group or compare to kids without MHE, but there is this tendency for scarring, keloid formation. Most of them, fortunately, are not true keloids where there's a mounding up of hypertrophic skin. Most of them are just these atrophic spread scars, and we don't fully understand why that happens. I think it has to do with the type 1 collagen abnormality and other factors, but the surgical technique is the same. We use, very careful surgical technique and have tried different variations, and it still happens, and it's not predictable. But we talk about that with the patients preoperatively, and there are some little things that we do to try and help. We're not sure, though, if they do or not, just because of the different confounding variables. And the other thing I wanted to mention here that's not in the slides is, and I was listening to Sarah's remarks, heartfelt remarks. It was excellent to hear her experience again. But the role of anesthesia for these surgeries, I think the CHOP in most large tertiary children's hospitals has an anesthesia pain service, and maybe one of the biggest advances in the surgical management of patients with MHE is getting the anesthesia team involved preoperatively, identifying what medications work best for the child, peripheral catheters, nerve blocks. All these little things make a huge difference for the patients and families, so they're not suffering, hurting after the surgeries. The disease burden, Harsha pulled a couple articles just looking at quality of life factors, and this was a good review for me, but there is a disease burden. This does affect lives. It affects job selection, mobility, quality of life. Different studies looking at using SF-36 tools, self-esteem, et cetera, et cetera. So there certainly is a need for a better way, something better than what we do in the operating room. Future developments define, what happens whereby this condition arises. Is there a role for pharmacologic intervention? Maurizio, I think, and others are looking hard at that. Pathogenesis, natural history is key for us as surgeons, selecting patients, which ones are going to get in trouble, which ones aren't. Gene therapy. So hopefully within our lifetimes there will be something that there will be a meaningful difference in the treatment of this. Finally, Maurizio did a nice job of illustrating some of the history of Philadelphia. I encourage you to check out the Mutter Museum. How many of you have been to the Mutter Museum? It's worth the visit if you have some time. This is a collection of anatomic specimens. It's great for Halloween time of year, but it illustrates the evolution of research. Back in the 1700s, 1800s, scientists were collecting specimens and classifying, and that's really what this museum is known for, and very, very different from what scientists are doing now. But there is, I think, a complete skeleton of a patient with MHE, and there's many individual bone specimens from MHE patients in this collection, but also, hundreds, if not thousands, of other medical curiosities. It's like a Ripley's Believe It or Not type of museum. So thank you for the opportunity to be here. It's great to see many old friends and new friends. Welcome to Philadelphia. I hope you enjoy your stay. And again, I think this type of interaction, we were talking in the hall earlier this morning, we tend to be at the same meetings with the same people all the time. I can give Dror's talks, I can give Ben Allman's talks, I've heard them before, but I think when we're together with a diverse group of researchers like all of you, I think that's a true opportunity for improvement, advance understanding. So hopefully we'll have a lot of that this weekend. So thank you for the invitation. Yes, question.
Recently I saw a child that had, she was about 4 or 5 months old, and she had very large exostoses on her ribs, as did her father, presented the same way, which is sort of unusual for MHE. And I'm wondering, how often do you see that? And I know in the mice we see rib presentation, so is there something different about that group of individuals?
Yeah, there has to be some genotype-phenotype correlation there. It's not uncommon. Clinically, we see rib bumps all the time, and you wouldn't think that you would see them because the ribs are intramembranous bone formation. It's like that slide, facial bones. Very rare to see osteochondromas in the face or skull, but for some reason the ribs, it's not uncommon at all. We see them.
Well, I was just surprised because they were very large, and that was the way in this particular family, this is the way they present it, which is a little bit different than what I usually expect.
Yeah.
I expect to see them on the long bones and later on the ribs, but these are very, very large. You could see them without even an X-ray.
It's not uncommon for the babies, the first visit. I think it was either Craig or Sarah where the initial, finding was a rib bump. And I've seen that many, many times where the, family presents with an infant that has a bump on one of the ribs. And I think it's clinically important for the older kids. They can get fairly large exostoses, pushing on the lungs or the heart. So that's where the history helps me a lot. If they have pleuritic type of pain, we'll look carefully at the x-rays, and really you can see them best on a CAT scan. The CAT scan, there's a lot of irradiation, so we get limited reduced imaging CAT scans. The MRI, there's so much motion. The MRI is a slower machine, and with respiration you don't see as much, but usually you can still see what you need to see from an MRI, but they do occur. Yes?
A couple of questions. So I was curious about your comment that previous radiation therapy induces exostoses.
Yeah.
And is that only in children?
I think it probably is more in children. I don't see adults. I imagine you can get exostoses in young adults radiated and maybe even older adults, but it's going to be less common, less frequent, less impressive. But a lot of these high-risk ALL kids, they'll come in and they've had total body irradiation, and they've got 5 or 6 osteochondromas.
And their distribution is typical of the patients?
Yeah, I don't know the answer. I haven't looked at that. I don't have any data. It seems, from recollection to be, the most rapidly growing ends of long bones, but maybe a little more ribs, spine, and pelvis, just because that's where they get more radiation. They have these collimated dosing schedules now where they can deliver more radiation where they want it to the thicker parts of the body, so to speak.
And I presume nobody's looked at these exostoses yet in terms of their compositions or their genetics?
I'd have to do a Medline search. I bet someone has. Yeah, there's probably something in the literature. Do you know Ben or Dror or anyone in the audience? But I imagine if you do a Medline search, you'll find something.
And then one other question. If you have is there typically abnormalities in the growth plate when you see I'm not sure how to say this, but when the bone lengths are abnormal, is it typical for the exostosis to be contiguous with the growth plate, or is it independent of that?
Well, at some point it comes, from that abnormal perichondrium. You know better than I, the zone of Ranvier, the ring of Lacroix. I mean, that's where but then it migrates away, and for some reason it's a temporal, the abnormality is on and then off, and then the growth plate generally, not always, but generally resumes function. It migrates away. But sometimes they're contiguous. You'll see like a mountain ridge, and those I'll not operate on those. If the exostosis is contiguous with the growth plate, if I take it out, it'll keep growing, and it'll grow another one, and it makes it a little risky, getting your osteotome in the right place and not damaging the growth plate. So that's generally a contraindication for me, at least, to surgical excision if the osteochondroma is still contiguous with the physis. Maurizio.
John, in terms of natural history, so have you had, I presume you have had the opportunity to follow the same child for years. So if you were to, have you had the opportunity to monitor the same exostosis over time, and do they evolve?
Yeah, there are reports of them actually disappearing. There are reports of solitary osteochondromas disappearing, and I'm always a little skeptical. I think, it may be that they're just not getting the x-ray right. but it's convincing. Rich Davidson brought me a case of a child who had a solitary osteochondroma he'd seen 10 years before, and then they came back and it was gone, and there were good x-rays. It was a fairly convincing case. So they can improve. Bone does remodel, but the bigger the bump, the less likely it's going to change a lot. Some of the smaller ones get better.
Yeah, I was actually also thinking about whether the one becomes another in terms of morphology, pedunculated versus not. So
Yeah.
do they change over time? That's what
I
I'm
think
asking.
they
Not
probably
just growth.
change a little bit, but not a huge amount would be my impression on that. Yeah.